Hello everyone. Today I am going to discuss about the most common chronic disease in childhood, that is asthma. And this asthma is also the most common morbidity disorder in children for any chronic disease. So it is very important to know about asthma. Now, before we going for the treatment of asthma, it is mandatory to know the definition of asthma. So, asthma is defined by history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary with time and in intensity, together with variable expiratory flow limitation, is called asthma. So, what is the easiest way to diagnose a patient having asthma? First, we have to take history from any patient. If any patient having more than two of these following symptoms, then we take an elaborate history that show that the patient or the child may have these symptoms that is vary with time or intensity. It is increased with time or decreased with time or increased with intensity by having some exposure to some risk factor. Along with, we have to do a pulmonary function test. And in pulmonary function test, if there is decrease FeV1 or FeV1 by FVC is less, then we diagnose the patient may have asthma. So definition is quite simple. We have to take first history. If any of the two of this any four is positive, plus we have to do a pulmonary function test. If there is FeV1 is decreased or FeV1 by FVC is decreased, then we diagnosed this patient may have asthma. Now come to the pathogenesis of asthma. How these symptoms are present in asthma. So as we know, asthma start with some pathogen or antigen such like pollens, dust particle or any other thing enter into the respiratory tract. This antigen first get attached with the antigen presenting cells like dendritic cells. These cells take the antigen into their cell cytosomes and they present these cells to T cell receptors, and the Th2 cells get stimulated and get activated. These Th2 cells then released to different mediator, that is interleukin 4 and interleukin 5. These all are MCQs. This interleukin 4 then stimulate the B cell to proliferate more amount of IgE antibody. This IgE antibody then get attached with macrophage and the mast cell get activated, and the interleukin 5 which is released by the Th2 cell, this interleukin 5 then call the eosinophil to come into the respiratory epithelium. So there is activated macrophage and also there is huge amount of eosinophil present in the epithelium. This macrophage after getting activated then they release some mediators like histamines, bradykinins, and along with this there is other mediators. This mediator directly stimulate the goblet cell to proliferate more amount of mucus, and also these mediators also stimulate the vagus nerve present in the respiratory muscle. This vagus nerve gets stimulated, and this vagus nerve after getting stimulation they spasm the muscle, they constrict the muscle causing bronchoconstriction, and this huge amount of stimulation from the mast cell and the goblet cell produce huge amount of mucus. So there is a thick mucus layer present in the respiratory tract. Along with this activated eosinophil also release eosinophil cationic protein. This is an MCQ. And also major basic protein. This is also an MCQ. This is the main two things which is released by the eosinophil. These two is altogether called eotoxin. This eotoxin mainly stimulate the epithelium and goblet cell to produce more amount of mucus, and they also cause hypertrophy of this muscle and submucal layer. If we cut the bronchus of any asthma patient, then we found there is a huge amount of mucus layer, and the submucus is also thickened and the muscle was hypertrophied, and there is presence of huge amount of eosinophil macrophages, and also the goblet cell also proliferated more and more here. So this is the main pathology of asthma. As we see, the main small pathogens or antigen or pollens enter into the respiratory tract. They get stimulate the antigen presenting cells. The antigen presenting cells then stimulate the Th2 cells to stimulate and release more amount of interleukin 4 and interleukin 5. This interleukin 4 then produces more huge amount of IgE. So in biopsy we found there is a huge amount of IgE, and interleukin 5 release and call the eosinophil to come here. This IgE then activate the macrophage. This is also an MCQ. Macrophage. This macrophage get proliferated here, and this they release some mediators like histamine, bradykinin. This histamine and bradykinin and along with this other mediators stimulate the muscle and the vagus nerve, and this nerve gets stimulated, the parasympathetic nerve gets stimulated and cause bronchoconstriction. That's why there we give bronchodilator for this asthma patient. And there is increased amount of mediators, and to decrease the mediators we give steroid to decrease the mediator, and there is increased amount of mucus production. So that's why we have 3 or 4 only medication to relieve the symptoms of asthma. That one is short acting beta blocker or long acting beta blocker, that is called LABA and SABA, and we give steroid to decrease the inflammation, and we may give some montelukast or zafilukast, that is nicotine inhibitor, to decrease the mediator also from release from the macrophage, and also we give anti-interleukin drug like omalizumab, tocilizumab, and other things I will discuss later on. So these are the medication, and these are the main pathology by which asthma patient having some symptoms. Now, if we cut a section of a bronchus of any asthma patient, we found that, as I say, there is mucosal hypertrophy. There is normal, there is decreased amount of submucous layer, and there is huge amount of submucous hypertrophy, and the muscle get hypertrophied here, and the lumen is also decreased. So there is a shortness of breath for this. Now come to the diagnostic criteria for asthma in the age group more than 6 years. In this video, I tell about the diagnostic criteria of asthma more than 6 years. And the next video, I will tell the diagnostic criteria for asthma in children less than 5 years. The diagnostic criteria for asthma having two parts. First is from the history part. From the history, we have to take 4 main symptoms. If a child having 2 of the 4 symptoms, as I discussed before, that is wheeze, shortness of breath, chest tightness, or cough, then there is positive history to diagnose asthma. First, why wheezes happen? Wheezes happen due to bronchoconstriction. And shortness of breath. Why shortness of breath is there? Because of the bronchoconstriction, there is decreased amount of oxygen enter into the body or lung, and huge amount of carbon dioxide is trapped into the alveoli. This That's why there is shortness of breath. And chest tightness. Why chest tightness is there? Because of the bronchoconstriction, the workload of the chest is increased. So the patient find there is a chest tightness, and cough is happen due to increased mucus secretion. So if more than one type of respiratory symptoms is present, then we see, then we go to ask, is the symptoms having vary with time or in intensity? What do you mean by varying with time or intensity? With time means if the symptoms is worse at night or on walking. That means in the late night, what happened? The parasympathetic nerve activity is increased. As I say, parasympathetic nerve is causing bronchoconstriction. That's why the asthma is exaggerated at in the late night or early morning. If the symptoms is triggered by exercise, laughter, allergen, or cold air exposure, then we think about the child may have a asthma, because these are the main allergen. This allergen, when enter into the respiratory tract, the mast cell getting activated and causing respiratory symptoms. And if this works with viral infection, then we think about asthma. Now, after taking history, if we found that any patient is positive for the history, then we go for doing pulmonary function test or lung function test. And after doing lung function test, we have to see the FEV1 level and FEV1 by FVC level. If FEV1 is decreased or FEV1 by FVC ratio is also decreased at a lower level, then we definitely cause the patient having asthma. And along with this, we have to do a bronchodilator responsiveness test. How this procedure is done? So we have to do a basic pulmonary function test, and we have to measure the FEV1 and FEV1 is to FVC level. Then we give a short acting beta agonist SABA for 200, at a dose of 200 to 400 microgram, and we wait for 10 to 15 minutes. After that, we have to do again a pulmonary function test, and we measure the FEV1. If the FEV1 level is increased by 12% from the first or basic FEV1, then we call that the bronchodilator responsiveness test is positive, and patient is having definitely asthma. So if any patient is already taking short acting beta blocker or SABA, or if the patient is already taking LABA or ICH, then this procedure is changed to some extent. And before doing this bronchodilator responsiveness test, we have to tell the patient, if the patient is taking SABA, then we have to tell the patient to stop taking SABA 4 hours before doing the test. Or if the patient is taking twice daily LABA, then we tell patient not to take the last SABA 24 hours before doing this test. If the patient taking once daily LABA, then we tell the patient not to take the LABA for last 36 hours. Then we have to do a basic PFT first, and after that we have to give this short acting LABA 200 to 400 microgram dose, and after that we have to do PFT. If the ratio FEV1 FVC ratio is more than 12%, then we tell that the patient is positive for bronchodilator responsiveness test. So to diagnose a patient, if whether having asthma or not, we have to take first history and we have to see if patient having any one of the four respiratory symptoms. Then we go for pulmonary function test. If pulmonary function test is positive, then we go for bronchodilator responsiveness test. If all the three are positive, that means history is also positive, PFT is also positive, and the bronchodilator responsiveness test is positive, then we call the patient having asthma. Now, come to the assessment of asthma severity. Previously, this asthma severity is only categorized into four parts: after and before giving treatment. Now, the asthma severity is only assessed after giving the treatment for more than 2 weeks. This these changes is mainly happened in new GINA guideline. So we have to tell the patient having mild asthma if the asthma is well controlled after asthma therapy. What do you mean by asthma therapy? I will come later on. The child having moderate asthma, when the child is well controlled with low dose inhaled corticosteroid with long acting beta agonist. And what do you mean by severe asthma? Severe asthma means asthma remain uncontrolled despite of high dose of inhaled corticosteroid or with long-acting beta blocker, or the child is taking high dose of ICH LAVA to prevent the exacerbation, but the child having symptoms always throughout the day. But the exacerbation is controlled after taking high dose of inhaled corticosteroid or and lava. Then we call the child is having severe asthma. So asthma severity is always assessed after giving the treatment for more than 2 weeks. This is a new change done in GINA guideline. Now come to the asthma medication. Before going to the treatment, we have to know the asthma medication. Asthma medication is divided into three parts. One is controller treatment. What do you mean by controller treatment? Controller means to control the inflammation. As I say, there is increased amount of inflammation by releasing of the mast cell and the eosinophil mediators. To decrease the mediators and the inflammation, we have to give inhaled corticosteroid or oral corticosteroid. So this inhaled corticosteroid is given to decrease the mediator release and also decrease the inflammation. So this is the main drug to give asthma control management. And reliever means when the symptoms is already occurred, then we have to give some medication to relieve the symptoms. Low dose inhaled corticosteroid and formoterol. Previously, this in low dose inhaled corticosteroid is only present in the controller therapy, but in this new GINA guideline, this low dose inhaled corticosteroid plus formoterol, that means ICH plus LAVA, is come under the reliever therapy, and short acting beta agonist is also present in reliever therapy. And there is other drug that is called add-on therapy. This drug is only given to decrease the inflammation and decrease the interleukin. As I say, there is increased amount of IgE antibody. So to decrease the IgE antibody, we have to give omalizumab. We can give azithromycin to decrease the viral infection, and we give anti-interleukin 5 and 5R. This interleukin 5, what happened? What it can do? It increase the eosinophil chemotaxis. So we give anti-interleukin 5/5R receptor antagonist, that is mepolizumab. This is an MCQ. We can give dupilumab. Dupilumab is a anti-interleukin 4 receptor antagonist. We give a tezepelumab. Tezepelumab is antithymic stromal lymphopoietin. So these all are MCQs. This add-on therapy is to decrease the asthma severity. If any patient have severe asthma, it is not controlled by giving high dose of corticosteroid. Then only we can give add-on therapy to any child. So in this slide, this is the most important thing is inhaled corticosteroid and long-acting beta agonist is altogether now enter into reliever therapy. Previously, inhaled corticosteroid is only present in controller therapy, but now this concept is changed. Why this inhaled corticosteroid and LAVA is enter into reliever therapy? Because it is shown that if we give inhaled corticosteroid with LAVA for a long term, then there is a decreased amount of exacerbation than a patient only taking long short-acting beta agonist for the reliever therapy. That's why we give ICH and LAVA as a reliever therapy. Now come to the risk factor for asthma. This is very important slide. If we give high SABA use for a long term, then it is a risk factor for exacerbation of asthma. So what do you mean by high SABA use? High SABA use means by if any patient take more than 200 dose of canister per year, that means 600 times SABA in a year, then the patient may have a chance of having exacerbation of asthma in future, and the child having, and this is a risk factor for asthma exacerbation. Along with this, if the child having obesity, GERD, food allergy, smoking, pollution, ever intubated in their life, then we tell that patient having risk factor for asthma exacerbation. If any patient having an exacerbation of asthma in the last 1 year, then it is also a risk factor for asthma exacerbation. So these all are the MCQs. So if we give high SABA, then the patient may lead to exacerbation of asthma. So that's why LAVA and ICH is now enter into a reliever therapy. Now come to the asthma treatment. Asthma treatment is divided into 3 categories. First is less than 5 years, what I will discuss in my next video. Next is 6 to 11 years children and more than or equal to 12 years children. So there is 3 different treatment protocol is there. Now in this age group, that is 6 months to 11 years, 6 years to 11 years, the treatment having 4 stages. First, we have to see the presenting symptoms and we have to tell the mother to write a diary. In this diary, we have to tell the mother take a proper date and take history of any day symptoms for which the child taking reliever therapy. Then night awaking, and last is exacerbation in the last 3 months or 1 year. We tell the mother to do this diary, make this diary properly. After that, we have to give the patient the therapy based on this diary. If any patient having less than 2 times in a month of asthma symptoms, or patient along with this having no risk factor for exacerbation for last 1 year, then we give only short acting beta agonist for as-need therapy. What do you mean by as-need therapy? As-need therapy means if the child having symptoms of asthma, then we only give short-acting beta agonist to relieve the symptoms. That is called as-need therapy. That means if the patient having cough in a day, then we give short-acting beta agonist for that day only. Next, this is stage 1 treatment. In stage 2 treatment, if the child having 2 or more than 2 in a month of asthma symptoms but less than daily of asthma symptoms, or the child is not having any exacerbation of asthma for the last 1 year, then we start the low dose inhaled corticosteroid and as need short acting beta agonist. This control therapy is only given to decrease the exacerbation and also to decrease the inflammation in the bronchus. That's why we always give low dose inhaled corticosteroid if any patient having symptoms more than 2 in a month. This is stage 2 treatment. In stage 3, if any patient having 4 to 5 days in a week of asthma symptoms or child is awake once or more than one time in a week, then we go for low dose of inhaled corticosteroid plus long acting beta agonist and along with this as need therapy of SABA. This is the new changes in the GINA guideline. So previously there is long acting beta agonist is not present in stage 3 therapy, but in now it is this long acting beta agonist is given in stage 3 therapy along with the inhaled corticosteroid. So if any patient having 4 to 5 days of asthma symptoms in a week or any patient having more than or one night awaking in a week along with risk factor is present, then we straight away go for long acting beta agonist and low dose inhaled corticosteroid. So if a patient only having night symptoms without having day symptoms like this, we also go for stage 3 therapy. In stage 4 therapy, any patient is present in an emergency with acute exacerbation with low lung function or severely uncontrolled asthma, then we straightly go for medium dose inhaled corticosteroid along with this long acting beta agonist and as need therapy of SABA. So this is the treatment protocol for asthma in a child group of 6 to 11 years. So we have to take the history properly. If patient having less than 2 times of the symptoms in a month, then we give only short acting beta agonist in a stage 1 therapy, that is as need therapy. If patient having more than 2 times but less than daily, more than 2 times in a month but less than daily in a month, then we go for long acting, then we go for low dose inhaled corticosteroid and SABA. If the patient having night awaking or that almost everyday symptoms, then we go for long acting beta agonist plus ICH and with SABA. And if the patient is present to you with acute exacerbation, then go for medium dose inhaled corticosteroid and LABA and short acting beta agonist as a as need therapy. Now come to the treatment of asthma in age group more than 11 years. In this age group, we again have to take the history properly and we tell the mother to write a detailed diary. The diary contains date, the day symptoms for which we give that reliever therapy the night awaking, and the acute exacerbation for the last 3 months or in a year, for which they go to doctor. And we categorize the child into 4 categories, and we start the treatment. In stage 1, if the child having less than 2 times in a month of asthma symptoms without any risk of exacerbation for the last 1 year, then we go for as need therapy of low dose inhaled corticosteroid and long acting beta agonist. This is an MCQ, and this is the new changes in GINA guideline. Previously, as need therapy of short acting beta agonist is there, but nowadays it is low dose inhaled corticosteroid with a LABA is given instead in the place of SABA, because if we give only SABA, that there may be a chance of exacerbation for a child, and the chance of exacerbation is much more low if we give low dose inhaled corticosteroid with LABA as need therapy. Now come to stage 2 therapy. In stage 2, if the patient present 2 or more times in a month of asthma symptoms but less than daily symptoms, then we go for stage 2 therapy as need therapy of inhaled corticosteroid and formoterol, that means LABA. So in a easy manner, if any patient having more than or less than 2 symptoms in a month without daily symptoms, then we go for as need therapy of LABA and ICH. If the patient having night awakening more than or equal to 1 time in a week, or the child having daily symptoms of asthma, then we go for low dose inhaled corticosteroid and LABA as a maintenance as well as need therapy. This is also new changes in GINA guideline. So in GINA guideline, they said after 11 years, there is no need of giving short acting SABA as a reliever therapy. We give as need therapy for ICH and LABA as a maintenance and as well as need therapy. This is stage 3. In stage 4 treatment, if the patient present to you with acute exacerbation or child having low lung function or severely uncontrolled asthma, then we go for medium dose ICH, LAVA as a maintenance and as need therapy. So this is the nutshell of treatment of asthma in a stage manner. In the first and second stage, we have to give low dose inhaled corticosteroid and LAVA as a as need therapy. This is the new changes in GINA guideline. And if the patient having daily symptoms or night awakening more than 1 time or more than 1 time in a week, then we give low dose inhaled corticosteroid and LAVA as a maintenance as well as need therapy. Or if patient is present with you as acute exacerbation, we give only medium dose inhaled corticosteroid and LAVA as a as need therapy as also maintenance therapy. Now, as I say, low dose, high dose, medium dose of inhaled corticosteroid. What do you mean by low dose, medium dose, or high dose? For inhaled corticosteroid, for the budesonide, if age is more than 12 years, then low dose means 200 to 400 microgram per day is called low dose. Medium dose is more than 400 but less than 800, and high dose is more than 800 microgram per day. For the age group of 6 to 12 years, that is low dose means 100 to 200 microgram per day, medium dose means 200 to 400, and high dose is more than 400 microgram per day. After giving the treatment, we have to assess that the patient is controlled by the treatment or not. That means what treatment we have given to the patient, does it is control the asthma of the patient or not. So assessment of asthma control is done taking four parameters. First parameter is daytime symptoms if present more than 2 times per week, any night symptoms present or not, short acting bronchodilator taking more than 2 times per week to relieve the symptoms, or any limitation of the day-to-day activity. We give 1 mark for these four parameters, and if the sum of these four parameters is 0, that means the child is well controlled after giving the treatment. If the sum of these four parameters is 1 to 2, then it is called partly controlled, and if the sum of these four parameters is 3 to 4, then we call this is uncontrolled. That means what we gave to the patient, it is not appropriate for these symptoms, and the asthma is not controlled by this treatment. So we have to step up the treatment. If the child is well controlled, then we continue the therapy for next 3 months. This is, we have to know, we continue the therapy for next 3 months, and we assess again after 3 months of treatment. If the patient is partly controlled, that means symptoms is controlled but there is presence of some amount of symptoms, then we step up the treatment to next stage. Or it is uncontrolled, then we also step up the treatment. And we also in partly controlled, we have to modify the risk factor. So what are the risk factor? As I say earlier, we have to modify the risk factor in both this group and this group. So we need to modify the risk factor. After modification of risk factor, we assess after 2 weeks. If after 2 weeks, if the symptoms is controlled, then we continue the therapy. If the patient having partly controlled, then we step up the therapy. Or if the patient is uncontrolled after modification of therapy, then we step up the therapy as I said before. So in a easy way, that means if symptoms is controlled, well controlled, then we continue the therapy for 3 months, and then we step down the treatment. If patient is partly controlled, then we modify the risk factor, and if assess and assess after 2 weeks. If the patient is well controlled, then we continue the therapy. If the patient is partly controlled or uncontrolled, then we step up the therapy. In case of uncontrolled, then we start stepping up the therapy, and also we do the modification of the risk factor. Now, what do you mean by stepping down of treatment? Stepping down means if the child is on stage 4, then we step down to stage 3. If the child is in stage 3, then step down to stage 2. If the child is stage 2, then step down to step 1, or so on. So after symptoms well controlled for next 3 months, we do a lung function after 3 months, and if the FPV1 and FVC report are present in a plateau phase, that means it is similar to after 3 months and before 3 months, then we step down the treatment. How do we step down the treatment? If a patient is on step 4 of treatment, that means moderate ICH with LAVA and as-needed therapy of SAVA, then we reduce 50% of the ICH dose. That means moderate ICH, we step down to low dose ICH. Now in stage 3 therapy, that means if the patient is on stage 3 therapy, that means low dose steroid with formoterol, then we reduce to once daily dose. Firstly, we have to give twice daily dose in any patient. After the child is well controlled by giving the treatment, then we shift to once daily dose. Okay, and in case of step 2 therapy, that means as need therapy of low dose in ICH with long acting beta bronchodilator, then we give it as need therapy as like step 1. So this is for age group more than 11 years. For age group from 6 years to 11 years, if the patient is on step 4 therapy, that means moderate dose ICH with LAVA and as need therapy of SAVA, then we reduce to 50% of the ICH dose. That means low dose. Go to low dose. If the child is on step 3 therapy, that means low dose ICH with formoterol LAVA, then we reduce to once daily dose. Previously it is given as twice daily dose, now it is reduced to once daily dose. And if the patient is on step 2, that means low dose inhaled corticosteroid plus as need therapy of SAVA, then we go only as need therapy of SAVA and we reduce the ICH to once daily dose, and after 3 months we stop the ICH. Okay, now come to the inhaler giving devices. Most common MCQs come from this part only. If the child is between 0 to 3 years, then we give metered dose inhaler with spacer with face mask. If the patient is on 4 to 5 years, then we give metered dose inhaler with spacer with mouthpiece. It is recently changed that face mask may not be needed for this patient. We can only give mouthpiece. If the child age is more than 5 years, so metered dose inhaler with spacer is given only, and plus minus mouthpiece if the patient is not taking the MDI well with these two. So these are the MCQs mainly asked from asthma patient. In the next video, I will discuss about how to diagnose a patient having asthma or not in an age group less than 5 years, and I also discuss about the management of asthma in a patient less than 5 years.